a bilateral lower limb weakness. So uh, thank you for the willingness to present the case, to challenge my thinking, and for all of us to learn. So human DX cases, I think they a different kind of challenge, because during discussing the case, there's something that is, I mean, there's a lot of uncertainty around, including the setting in which the case comes from, which I think offers some important information. But then it's a lot of learning during. So whenever I discuss a human DX case, I learn a lot of things. So was it a 30 years old female, or did I miss? Or was I exactly the age? Is it 30?
30 female, yes.
Yeah. So she presents with bilateral lower limb weakness. I will not take a lot of time here, but whenever I hear weakness, the first effort that I make is to make sure that I distinguish between true neurological weakness, which is weakness that I'm going to talk about in a short while, from other causes that can be confused with true neurological weakness. So those other things are like someone can have prostration. So, for example, someone is critically ill, or they are suffering from some illness which doesn't cause true neurological weakness, but because of prostration, then she presents, or she comes with a presentation that is confused with neurological weakness. Another thing is rigidity. So someone can have rigidity, and the muscles are not weak, and you can confuse it with true neurological weakness. Another one is pain. So someone can avoid using a limb because of excruciating pain, but otherwise there is no weakness. And another one is apraxia. So in apraxia, someone doesn't have weakness, but then execution of complex movements is impaired because of some abnormalities in parts of the CNS, but otherwise the patient is not weak. So, for example, someone can be unable to, for example, to button or unbutton their shirt, but they can raise their limbs normally. So that is not weakness; it's apraxia. So I try to distinguish. So that is the first effort that I try to make, to distinguish true neurological weakness from those. And then once I am sure that it's not those weakness mimics, then I'll go down the path of thinking about weakness, and I consider the neuraxis as a whole. So when you hear weakness, it can come from any point. You are talking of something in the CNS, and the CNS here, I include the brain as well as the upper motor neuron part of the spinal cord, that is anything above the anterior horn cells. So weakness can be coming from then. The other one now is when you have anterior horn disease, motor neuron disease, neuromuscular junction disease, and muscle disease. So weakness can come from any point. Now, because with this patient, we are told that she has bilateral lower limb weakness. So there's some information that I'll need to hear. Like the pattern of the weakness, whether it's predominantly peripheral, distal or proximal. But another thing, of course, if there are any bladder or bowel symptoms, if there is, and especially when it comes to physical examination, if this is associated with the sensory level, if there are sensory symptoms, because when you hear of bilateral lower limb weakness, then it could be any of the things that I mentioned. It could be a muscle disease. Last week we discussed the case of dermatomyositis, which presents with bilateral weakness, which is symmetrical. And of course, it might as well be neuromuscular junction disease. It could be motor neuron disease, but it could be disease that is coming out of the spine. So, for example, you could be dealing with the myelopathy. So, I think many thoughts at this point, but a focused HPI will help me make progress. So, back to you, Joseph.
Okay, thank you. So let's see the HPI. So the weakness started 2 to 3 weeks ago. It is bilateral in both legs, and it's worse in the legs and minimal in the hands. She denies any prior similar episodes, but also she denies diarrhea, change in urination, trauma, recent diuretic use, or recent laxative use. That's a short HPI.
Okay, this is very interesting. So, you're saying the weakness is worse in the lower limbs, but it seems it's also is it also present in the upper limbs, because you said it's worse
Yeah,
in the lower limbs as compared to the upper limbs, so also present in the upper limbs, but the pattern of the weakness is not mentioned, whether the patient is having difficulties rising from a sitting position, raising arms above the head. Nothing mentioned of that sort.
yeah, nothing.
Not mentioned. And then we are told the patient has no history of trauma. So, I mean, because as it seems, I mean, the history is not very detailed, but as it seems, there is also upper limb involvement. And at this point, we are not sure about the pattern of involvement. And so, because there is also upper limb involvement, but the lower limbs seem to be more involved, then what we are talking about could be, if you are talking about a spine issue, if you are talking about a myelopathy, for example, then it should be something that is in the high cervical, because with upper limb involvement, it's not likely that it's something that is coming out of the thoracic area or lower than that. So if it's a spine issue, then we are talking about something high cervical. But another thing that we are talking here is that this patient has no history of diarrhea, right? Right, Joseph? No diarrhea. I remember no diuretic use and
Yeah,
no
not diarrhea.
laxative use.
Sure.
Yeah. So, I mean, diarrhea with weakness, you can talk about a number of things. For example, electrolyte imbalance, as in hypokalemia, and of course the same issue with diuretics. If you have electrolyte abnormalities like hypokalemia, you can present with muscle weakness. And another thing is diarrhea can be tied to this when you talk about an acute demyelinating polyradiculoneuropathy like GBS and related conditions, because those ones can be preceded or anticipated. Can be preceded by a GI illness like a gastroenteritis. So this patient doesn't have any of those, and then there is no trauma, which means so something like a compressive myelopathy, for example, from uh, vertebral fractures, or a disc herniation which compresses the spinal cord. Those are not likely in this patient. So I think for me, this history was too short to at least localize or determine what exactly is going on. But the duration, you said it's about 3 weeks, and I do not remember any mention of whether the weakness peaked immediately or if it was progressive. I do not remember any mention of that. But let's hope that other components of the history, because again, we did not hear the review of systems in order to see this is a systemic issue or if it is just localized to the, or if it is a localized issue. And so let's see if there is a review of systems that can help us make progress, but otherwise we can also make further progress when it comes to physical examination. So let's proceed, Joseph. And if there's anything that I missed there, please remind me.
Yeah, so the author of the case proceeds to physical exam. and I'll read to you the physical exam. So the vital signs are normal. General appearance, patient is anxious. Uh, the motor exam, 5 out of 5 in upper extremities bilaterally, but 0 out of 5 in lower extremities bilaterally. Other
Joseph, you are breaking. I'm not sure if it's my internet or that's the case with everyone. So can you start the physical examination afresh?
Yeah, how about that? Can you hear me?
Come again.
Can you hear me?
It's breaking. I'm not sure if it's only this side. Can everyone else hear Joseph clearly? Joseph, can you try again?
Yeah. So can you hear me?
Let's proceed. In case I do not hear some things, I will let you know in case I miss anything. But your voice is breaking.
Okay. Yeah. So I was reading to you the physical exam, and I started with the vital signs, which are within normal limits. General appearance, patient is anxious. Motor exam, power is 5 out of 5 in the upper extremities, but 0 out of 5 in the lower extremities bilaterally.
In the lower extremities, how
Zero,
much over 5?
zero. Do you get that?
And when you came to the lower limbs, I missed that.
Yeah. So lower limbs is 0 out of 5.
Okay, let's proceed.
So yeah, to shorten it, the rest of the neuro exam is normal, like the deep tendon reflexes, the sensory exam, they're also normal. Yeah, that's it. Other systemic exam is also normal. Maybe you can discuss those physical exam, and go to the labs later.
Yeah, so with the you said power of was 5/5 in upper limbs and 0/5 in lower limbs, and no
Yes,
mention. Is it same in all muscle groups, or that is also not mentioned?
it's not mentioned.
Not mentioned. So I will just say so power is 0/5 in lower limbs, and then you said sensory examination was normal.
Everything else is normal.
So I'm assuming sensory examination normal. So that means uh, there's no sensory loss and no sensory level in this patient. So it's just power 0/5 in both lower limbs, tone, reflexes, normal, right? Okay, so power 0/5 in lower limbs and then everything else normal. Can you repeat those other parameters that
Yes.
were mentioned? Can you
Every
repeat those?
So everything else, including the tone, deep tendon reflex, sensory exam, they're all normal.
Okay. Yeah, so I mean, they again, like in the history, I think there are some things that are missing here, but let's assume that the power is 0/5 in all muscle groups of the lower limbs, which means if you are talking about knee extensors, knee flexors, the same applies to the hip, the same applies to the ankles. So it's 0/5 in the lower limbs with other findings normal, translating that as muscle bulk normal, uh, no abnormal movements that are seen like fasciculations, deep tendon reflexes are normal, and then tone is also normal. So, I mean that is something possible, something possible. So when we talk about, for example, if we were talking about an upper motor neuron disease, it's possible to have an upper motor neuron disease with normal findings. Not all of them will be normal. So, for example, we would expect hyporeflexia in spinal shock. But then, and yes, it's also possible to have a spine disease with no sensory symptoms. It's a possibility, but so with spinal shock, for example, we would expect to have hyporeflexia if we are talking about spinal shock that is in the acute phase of the disease. But otherwise, if you talk about an upper motor neuron lesion, we would expect hyperreflexia, hypertonia on top of the weakness, which we do not hear in this patient. And so I think with that, I think there's it's either I'm struggling to make sense of it or I'm missing some pieces of information. But I think what I will think about more is something like, for example, when you talk about uh, an acute demyelinating polyradiculoneuropathy like GBS, it can present in this way. You are just having weakness and then no prominent sensory symptoms. So the other things, I mean, they can go. You do not expect features of an upper motor neuron lesion. So a demyelinating illness like GBS is a possibility, and then we could see the same picture, for example, with a muscle disease. But then with the muscle disease, we expect the weakness to be more proximal rather than distal. And so that's what goes against a muscle disease like an inflammatory myopathy, like dermatomyositis, or other sorts of inflammatory myopathies that we can think about. So I think at this point, I mean, with the limitations that I have, either I'm missing some things or maybe the information right from the history and the physical examination was not that adequate. But I'm thinking on top of the list, I could consider something like GBS, for example. Although let's see, I expected to make more progress than this when it comes to physical examination, but let's hear the labs and other investigations that we have in order to see if I can make progress.
Yeah, I agree with you. The exam is limited, but it's the patient from US and internist and neurologist, two different parts. So, can you hear me now, David?
Yes, I can hear you.
Okay. I'll read the labs in parts, and let me start with the first part. So, here is the metabolic panel that is being placed here. Fuba picture is normal. So sodium is 140. I think you can not decide if you wish.
Your voice broke when you talked about the CBC and sodium.
CBC is normal.
Okay,
The sodium is 140, normal.
114. Okay,
Potassium 1.6, low.
okay.
Chloride 113, high.
Yes. What was that after potassium?
Chloride.
Oh, you broke. I couldn't hear that.
Okay.
Yes, I can hear you. Yes, I can hear you, Joseph. One 13. Okay. Okay. pH 7.21. Okay. PCO2 I didn't hear that. Yes, 21. Okay. Can you come again with the? I'm not sure. Did you say ABG or VBG? Because your ABG. So you said PCO2 21, partial pressure of oxygen. You say one. Is it 120? 129. And then you said the bicarb there was 8.2. Okay. And was there something else in that ABG? 7.21. Okay. Are you speaking, Joseph? Okay. Should I discuss those first? Okay. So what I'm picking, what I'm gathering from this is so a CBC is normal, sodium 140, and then you say potassium 1.6, right? And then the chloride was was it 116 or 119, but it was high, as I recollect what you said. And then the bicarb was 11. I think in one you said 11, and then in the ABG it was 8.1. Yeah, and what else am I missing? The pH is 7.21. So this patient has acidemia. Let me just start by saying acidemia. So the pH is low. The normal range that I use is 7.35 to 7.45. So the pH is low, and the bicarbonate is also low, which is and the cutoff that I use for bicarb. I know different people have different cutoffs, but is that 23 to 28? Well, it may not be very accurate, but then whichever the cutoff that you use, whether 21 or 23, this is very low. So that's 1 point that you said in one more it was 11, and then in another, in the ABG, it was 8 point. So the bicarb is low, the pH is low, the partial pressure of carbon dioxide, you said 21. Can you remember, can you remind me the normal range if you have it there? And the partial pressure of oxygen was 120 something, and if if you have the normal ranges, also remind me. The partial pressure of carbon dioxide is low. The partial pressure of carbon dioxide is low. And then what about the partial pressure of oxygen there? Is it, are they using the cutoff of 80 to 100, or is it, does it go beyond that? Or they did not report on the normal ranges? Okay. Also, yeah, so what I'm seeing here is I think I'll have some difficulties talking about the direction and coming to a conclusion about the exact kind. What I have here is that at least there is a metabolic acidosis. Metabolic acidosis because the bicarb is low and the pH is low, so they are both going in the same direction. And again, but also the partial pressure of carbon dioxide is also low. So I think I'll have to remind myself of the math, especially calculating. Yes, so we had we had the sodium, which is 140. We have the bicarb. I think what I'm missing here is what am I missing here in order to calculate yeah, we have the chloride. So I'll do I'm not sure about I'm not sure about the units there, but let me quickly calculate the anion gap here. So chloride was was it 16 or 19? 113. Okay, 113, and then a bicarb of 11, is it? In the first one, was it 11? Okay, and then so this adds to 124, and we have a sodium of 140, right? Yeah, so the sodium was 140, so minus 124, 16. So this is an elevated anion gap. Elevated anion gap. So I think I'll fumble a little here, but I'll say that this is a high anion gap metabolic acidosis. And so whether because I didn't there's this other question equation which I do not remember correctly, to see whether this was compensated or not compensated, and if there is any mix the picture. But at least we have a high anion gap metabolic acidosis, and there's a number of differentials for that. I think I'll not remember all of them. And so the other thing is we had a low potassium. We had a low potassium. So the weakness that this patient is presenting with, as we saw that other things were not very in keeping, so for example, if you talk of a motor neuron disease or something in the CNS, including the spinal cord itself, it was a picture close to that of like GBS, but then we're also seeing electrolyte abnormalities with an acidosis. So this could be something metabolic that is explaining, because as I said, electrolytes can also present with muscle weakness, especially hypokalemia. Now you are having hypokalemia and metabolic acidosis. So I think I'm very limited, and I'll struggle to make a diagnosis here. But one thing that comes, I mean, as a reflex is, I know there are some types of renal tubular acidosis, which can present. So you have acidosis, and then you also have an electrolyte abnormality like hypokalemia. I think I'll consider that as part of this story. But another thing is, when you're talking about high anion gap metabolic acidosis, so there are some sorts of poisoning that can present that way. So, for example, if you talk of salicylate poisoning, uh, if you talk of ethylene glycol, and and of course we shouldn't forget diabetic ketoacidosis, which is also a high anion gap metabolic acidosis. But then we do not see anything that points us in the direction of DKA. Because this patient, the glucose was normal, and then we do not have anything else, at least in the history, that is pointing us in that direction. I know that you can have euglycemic acidosis, but that is commonly seen in pregnant women and maybe patients who are using SGLT2 inhibitors like dapagliflozin. Of course, we do not know the last normal menstrual period of this patient, and we do not have a history that this patient has diabetes. So I think that is what I make out of the initial labs that we presented. I think there is a lot that I'm still missing. So I'm very excited to learn later what I'm missing, because I think my knowledge is very limited here. So if you have any other labs, let's proceed. Can you come again with the renal biopsy? Okay. Anything else, or do I discuss those? Interesting. The extra labs that you presented, you said complement levels were low, and then anti-Rho and anti-La were high titers, but anti-double-stranded DNA was negative, and then renal biopsy, patchy, interstitial inflammation, right? Okay. Especially with the renal biopsy, I do not have a lot to make out of it, but let me just say this, that so anti-Rho and anti-La, these are autoantibodies which when I hear about, I think more commonly about Sjogren's. But then I know that they can also come with other autoimmune diseases, including SLE itself, including mixed connective tissue disease and overlap syndromes. So they can be there. We did not hear any Zika symptoms in this patient, like eye dryness, mouth dryness, or anything of that sort. But now, since I talked about a possibility of renal tubular acidosis, I think I'll have to go back again and see about the criteria for making a diagnosis of renal tubular acidosis. If I remember correctly, I think there's something about the renal function. Basically, you are not supposed to have impaired renal function, which means the creatinine, for example, should be normal. We are not, I do not remember you mentioning the creatinine, whether it was normal or elevated, but I know that autoimmune diseases, some autoimmune diseases or connective tissue diseases in general, can be associated with renal tubular acidosis. So there's renal tubular acidosis that can come isolated, and you can have renal tubular acidosis that comes with other diseases, including autoimmune diseases. So with this patient, there are positive autoantibodies and then low complement levels. So low complement levels, again, I think I do not have all the differentials for a low complement level, but basically one of the things is that there's consumption of the complement. So complement activation consumption because of something that is going on. And so I tend to associate more, especially when you talk of C3, C4 with SLE. I believe it's the same with some other autoimmune diseases. So so what I hypothesize is that there's some immune mediated process that is going on with this patient. And with the positive autoantibodies, I think I'll have to consider those autoimmune conditions that we talked about. And so this weakness that the patient presented with, I think, in absence of other abnormalities, especially on a neurological examination, because with normal parameters in the deep tendon reflexes, it's either we could be talking about something like GBS, in which case we'd also need nerve conduction studies that will tell us that there is a demyelinating process that is going on that is not reported in this patient. But then we have a metabolic explanation for the weakness, which is hypokalemia. And this hypokalemia is associated with the metabolic acidosis and also associated with a probable immune-mediated process that is going on, leading to an elevation in autoantibodies, an interstitial process in the kidneys, and then low complement levels on top of this picture that is seems to be consistent with renal tubular acidosis. So I think when we talked about the hypokalemia, I did not discuss other possibilities. And so Joseph will be aware of this. There is this saying that when you see hypokalemia, one question is, where did the K go? Where did the potassium go? So it's either the potassium moved into the cells, the potassium moves into the cells in, so for example, when someone takes in, when there's insulin, for example, or when there's a beta adrenergic stimulation, like for example, someone uses salbutamol, and potassium can also move into the cells in hyperthyroidism. So I think if I remember correctly, we discussed the case of thyrotoxic periodic paralysis one time in these sessions. But we were not told if this patient had features of hyperthyroidism, and of course that is periodic paralysis. This patient has experienced limb weakness for more than 3 weeks. So that is just some of things that will move potassium into the cells. So insulin, beta adrenergic activation or beta adrenergic agonists, hyperthyroidism, and then barium. So apart from that, so another thing, of course, is it acidosis? Now, I think I confused this many times. So between acidosis and alkalosis, one of those also moves potassium into the cells. I think if it is part of the teaching point, so if Joseph remembers that, he'll remind me later. So apart from that, apart from potassium movement into the cells, you have GI loss, either through vomiting or diarrhea, which are not present in this patient. Vomiting, diarrhea, suctioning, and so those can come as a result of use of laxatives, which we are told this patient didn't use. Another thing is increased renal loss of potassium, which happens with diuretics, for example. And it also happens with, for example, when someone vomits because of increase the delivery of negatively charged ions bicarbonate in the distal nephron. Another thing is when you have hyperaldosteronism. Hyperaldosteronism will will lead to increased potassium loss. But this patient didn't have features of hyperaldosteronism because yes, the potassium is low. These patients commonly present with hypertension. We are told the vitals were normal. So hyperaldosteronism is not a possibility in this patient. So another thing is there are some medications that can do that, but we did not hear any significant medical history that would tell us, at least we know diuretics are not. There are some antibiotics which can do that. Lithium can do that, and some other medications. We do not have a significant medical history. So I think those ones that I should discuss in this patient, I already talked about renal tubular acidosis. Another one is, I'm sorry that I cannot specify the type of renal tubular acidosis that is going on in this patient because those are not frequent encounters for me. I do not remember managing a patient with RTA. So most of my encounters are just through reading cases, and therefore when it's just through reading cases, retention is impaired also sometimes. And so specifying whether this is more of a proximal or distal renal tubular acidosis, I think if I try to strain much, I might be able to come close, but for the sake of time, I'll not try to do that. So other things that can come with hypokalemia are genetic abnormalities of potassium transportation. So there's Liddle syndrome, Gitelman and Bartter syndrome. So I think what I think I'll probably miss the diagnosis in this patient, but what I'm thinking of is there is an immune-mediated process that is going on, an autoimmune process, which we do not have signals from other systems because there were no joint symptoms, no integumentary system symptoms that we had in this patient. So nothing else that is pointing in the direction of autoimmunity apart from the weakness that is better explained by the hypokalemia. But because of those findings of low complement and high titers of autoantibodies, I'll say it's an autoimmune process uh, that has caused an interstitial nephritis picture that is presenting with a renal tubular acidosis. So I think that is a broader diagnosis that I have. So I'll just sit back, relax, and learn from the case resolution. So back to you, Joseph. Yes, yes, I see your screen. Can you move? Yeah, yeah. Can you scroll down so we can see uh, the the things that fall under renal? Yeah, yeah. Joseph, can you try and fix your internet because it's breaking, and I think we are at a very important junction to learn. Can you try and fix in order so we can follow because it's breaking from point to point? Just try and speak up. We'll see if we can follow. Yeah, I mean there are sentences that come very clearly, and then afterwards you keep breaking from time to time. Can you come again with that? This was a case of renal. I think you said Sjogren's, but then it renal Sjogren's, right? Okay. Thank you very much. So, turns out, I'll tell you that, of course, as although I talked about Sjogren's, and then I threw a big umbrella of an autoimmune process leading to the renal tubular acidosis and all that. But I'll tell you that this is, I think, the very first one of this kind to see something in the kidneys, and then you do not see anything else with the I mean in the Zika symptoms are not present, and of course I think that is it's so that means maybe as if the patient over time the natural history of the disease, maybe a point will come when, because if biopsy of the salivary glands revealed the lymphoplasmacytic infiltration, so that means it's just a matter of time the patient will present with the Zika symptoms. So yeah, I think it was so for me huge learning, because so to begin with, the muscle weakness that we were dealing with very initially, I think I was very focused on neurological causes of weakness until the point came when I heard about the hypokalemia. That's when my thinking shifted. That so this muscle weakness is explained by the hypokalemia. And so after that, I, afterwards, I think okay, let me try to mute this. Hello, Emmanuel, can you try to mute for oh, I'm trying. I'm not sure if not sure what happened with my admin controls. I cannot mute him. Emmanuel, can you try and mute so we can so the background noise can. Okay, let me do this. Okay. I was saying that so initially I was thinking about neurological weakness until the potassium came, and so I shifted the thinking that it's the hypokalemia that was explaining the weakness, and then afterwards the issue was the cause of the hypokalemia. So I think some learning that I have to do here is to go back and review my my schema for acidosis, because so the cutoff that I use is 12 to 14. So you see, sometimes we can have these confusions. Joseph, you're using 12 to 16, you said, right? The different cutoffs point in different directions. And of course, that is the other thing that I missed, that RTA needs to be normal iron gap, right? So yeah, so I think I have to review more on acidosis. So RTA could come in this patient, but did they go to the details to talk about the type of RTA? Because there is proximal, there is distal, and if you talk in terms of types, there is about 1 to 4. Did they specify the kind of RTA in this patient? Okay. So there's yeah, so there's proximal and distal. I think distal is what goes with type 1. and then proximal is type 2, something like that, and then 3 and 4 are kind of a fusion. And yeah, so I think we'll also go and review more on those. But so interesting to learn that I think what made me uh, talk about the Sjogren's was because of the autoantibodies, so the anti-Rho and anti-La, and then the low complement levels. And then the biopsy, I was not exactly sure what to make out of it, but after hearing the autoantibodies, a theory that I made up was that an immune-mediated process that is going on in the kidneys leading to the inflammation and then the low complement levels. So, came close to the diagnosis, or the thoughts that I had, all of them were included in the final diagnosis, but I think a lot of learning that happened with the case. So thank you very much for the selection of the case and for the teaching. Yeah, I follow. Thank you very much, Joseph. It's huge learning for me today. So we are almost, I think, 1 minute to time, but we can spare a few more minutes if anyone in the audience has uh, any any inputs, any questions, any experience to share or anything. Please welcome before we close. I do not see any. I do not see any hands. Anything from you, Joseph? Okay, so if there is nothing, because I can't see any hands, it was good having everyone around, and thank you very much, Joseph, for the choice of the case. We'll be back here next week, but for people in the audience, if you have a case, whether complete or incomplete, please bring the cases. I know that there are people in this crowd who are seeing very interesting cases that we can learn a thing or two from. So if you have a case, please reach out and present the case. And also, we could benefit from switching in order to avoid the monotony. So if anyone is willing to discuss a case, maybe next week we should start with a volunteer who wishes to discuss a case, and then in case there is no volunteer, then we can go with the usual faces, because we need to learn from everyone. Otherwise, thank you very much for joining. Have a good night and see you next weekend.